And I'm going to have now a great pleasure to introduce our first keynote speaker, Dr. Peter Slavin. He's the CEO of and president of Mass General Hospital since 2003. In his past, he served also as the CEO of the physician organization of Mass General Hospital, held other major leadership positions in other hospitals and other systems. He's a trained physician, graduated from Harvard College and Harvard Medical School. He also made maybe not the most optimal decision and pursue an MBA in the Harvard Business School. But nobody is perfect, I guess. But let me just, before I let Peter Slavin, Dr. Slavin talk, I just want to share with you my personal experience. I've been working with MGH for the last 8 years, and I've seen firsthand the kind of leadership and vision that Dr. Slavin brought to the organization, and in particular, the desire to get better and seek out collaborations with other organizations. So I think it's going to be fascinating to hear from him. Thank you.
Thank you very much, Retzef, for that very kind introduction, and thanks to the Sloan School for inviting me to be here with you today. I'm a little bit, this feels a bit of a surreal experience for me because the work that I'm going to be presenting on the application of operations research to the operations of an academic medical center is work that Retzef has been a driving force behind. And I'm reminded of a story I heard about an academic physician who traveled around the country giving talks on his very exciting research, and at every talk he would have a driver drive him to the talk and then back to his hotel, the same driver all around the country. And at the end of a long trip, he was scheduled to give his last talk. In the car, he says to the driver, you know, I'm really tired of giving this talk. I'm really tired today. I have a great idea. Why don't we change outfits? You've heard me give this talk 100 times. You can give it as well as me, and you've heard all the questions that have been asked. They're all the same, so you can answer the questions as well. So the driver's a little bit leery of this idea, but agrees to do it and proceeds to give just an outstanding version of the talk and nails every question. And then as time is running out, he says, you know, we have time for one more question. Gentleman gets up and asks a question that is really very sophisticated and has never been asked before. And the driver pauses for a second and says, you know, that question is so simple, I'm going to ask my driver in the back to answer it. So if any of you ask me any challenging questions, I'm going to ask Retzef to answer it. My family and I have enjoyed a wonderful association with MIT that dates back almost 100 years. My grandfather, my mother's father, went to MIT. He grew up about 10 miles north in the city of Malden, was a very good student, was thrilled to go to MIT, and then probably two of the saddest things happened to him when he was at MIT. He lost his father, and because his father ran the family business, my grandfather had to leave MIT to run the family business and never had the opportunity to graduate, and that was one of the things in his life that he regretted the most. I had the honor, I guess about 7 years ago, of being appointed to the corporation of MIT, the governing body, and knew immediately when I stepped on the campus and heard about the incredible resources of MIT, what my grandfather was so enthralled by. So this is an amazing institution. I didn't have the smarts to go there, but I am extraordinarily impressed at what happens across MIT, including at the Sloan School. This is, I know you've heard over the course of the day, is an extraordinary time in healthcare. First, there's never been a time when we can do more to improve the quality of life for our patients and their loved ones. There's never been more scientific excitement about the future that I think can bring even better diagnostic and therapeutic techniques for our patients in the future. The science in medicine is truly breathtaking. Fortunately, we're also facing a funding crisis in biomedical research, which is making it less attractive for some of our most talented people. At the same time, there is a revolution going on across the country in terms of how to not only better understand the biology of healthcare, but how to understand how to deliver healthcare in a more reliable, high quality, and affordable way. And I'm very pleased that Boston, Massachusetts is taking a leadership role in that area in much the same way it did in trying to figure out how to enhance access to health insurance a number of years ago. And so we find ourselves in the midst of a very exciting and dynamic market where a ton of work is going on trying to figure out how to make care better, more affordable, and therefore sustainable for our country. So as Retzef said, I hail from Mass General Hospital, an institution right across the river from MIT. There's a bridge, the Longfellow Bridge, that connects the two institutions. Only half of it is open right now, so there's a little bit of stenosis that we are currently facing. But MGH has been around since 1811. It was founded by the state of Massachusetts to be an institution that would care for the poor people of Boston, because back in the early 19th century, healthcare consisted of doctors visiting patients in their home, and back in early 19th century, unfortunately, just like today, some people couldn't afford to pay the doctors, some people didn't have homes, and so this new innovation in healthcare, a general hospital was established to be a place where poor people could be cared for with dignity, and we continue to be one of the largest providers of care to disadvantaged populations in the Boston area. We have enjoyed a remarkable relationship with MIT that dates back almost 100 years. And if you go back in history, in 1936, the president of MIT, Carl Compton, gave a talk in Boston to a group of physicians from the various hospitals at that time, encouraging them to think about the exciting application of physics to medicine. A physician from Mass General, an endocrinologist by the name of Saul Hertz, went up to President Compton after the talk, because the talk was about, one of the things that Compton was talking about was the new development of the ability to produce radioisotopes. And so Hertz went up to Compton after the talk and asked, could iodine be made radioactive, because iodine is known to be very important in thyroid disease and physiology. Took about several months for Compton to get back to Hertz through a letter, but indeed, it was possible to produce radioactive iodine, and so Hertz and endocrinologists began working with nuclear physicists at MIT on first testing radioactive iodine in animals, and then eventually in humans. And as we sit here today, there are literally hundreds of thousands of people around the world treated with radioactive iodine for Graves' disease, thyroid cancer, and that is one of dozens of exciting innovations in healthcare that have come about through this wonderful collaboration between our two institutions. Our institution knowing a lot about patient care, a lot about biology, and MIT, in addition to knowing a lot about biology, knowing a lot about economics and physics and computer science, et cetera. So on this base of a very rich set of collaborations, as Retzef said, about 8 years ago, we began collaborating in a new dimension with MIT in the social sciences and through the Sloan School in the area of operations research. And this has been one of the most exciting things, I think, that's gone on at Mass General over the last 8 years. I think arguably, this is the most exciting application of operations research to healthcare that has been documented to date. And not only has it helped improve the care we deliver to our patients, but it also has led to great academic products for both MIT as well as Mass General faculty. So what I'd like to share with you today is some of that work. And as I said, this has been a wonderful collaboration between, on the left, our staff at the hospital, and the team at MIT led by Retzef. The team on our end is led by an anesthesiologist by the name of Peter Dunn, who is the medical director of our operating rooms, and Retzef leads the MIT team and has brought along some wonderful fellows and students, and has applied techniques that we know very little about at Mass General, data analytics, simulation, system process design. I should say, when I was a student at the other business school across and up the river, I was struck that operations research had some exciting applications in medicine. I was convinced that medicine was an operations research underserved industry, and I've been looking ever since I came back to MGH from business school in 1990 for a way to try to leverage this science to healthcare delivery, and we tried a number of other collaborations, none of which worked, either because people weren't very good at this or people didn't really understand how to help with the change management, which is another important part of affecting change. So we have worked, or Retzef and Peter have worked in a number of different areas in the hospital. The ones I'm going to share with you today are OR scheduling, primary care redesign, and the use, and some new things are now going on in hospital bed capacity management and provider scheduling within our primary care practices. But this is the, let me just go back here. This is the one where we have some, what I think are some very exciting results that have been presented in a number of national meetings and published as well. So this is part of the life of a typical teaching hospital or any hospital in the country, and I'm actually going to start on the right. If you look at the census of surgical inpatients in the hospital, and these are actual numbers from MGH from several years ago, on Sunday, our census at midnight is a little bit over 250, but over the course of the week, it peaks at about 325 and then drops down again on Saturday. So some pretty impressive non-random variation, and that in turn leads to these phenomenon. If you look at how long patients are waiting in our PACU, which is our recovery room after surgery, to go to a bed, you can see that the occupancy in the PACU goes up dramatically between 9 in the morning and 6 at night, while patients are not quite out of their beds and we're running a very high occupancy. And then because the recovery room is full, patients back up in the operating room because there's no slot in the recovery room for them to be transferred to. So as you can imagine, this system is not only not suboptimal from a efficiency and safety standpoint, but it creates lots of frustrations among the staff of the OR who want to get through their cases and are hampered every day by these bottlenecks. And so it's really this phenomenon here, the floor beds, which are the bottlenecks backing up the OR. So Retzef and Peter looked in more detail at what was causing this non-random variation. Here again is the surgical census over the course of the week. And in most hospitals, you measure the hospital occupancy is measured at midnight when all of the dust is settled during the course of the day. It really should be measured in the middle of the day when patients haven't left yet and patients are beginning to arrive. And you can see that on most days we are well over our surgical capacity of beds. And then when you break down the census into 4 different patient groups, those who actually aren't in the hospital for surgery at all, those who are on the wait list, which are emergency cases, those who are elective patients with lengths of stay less than 7 days, and those who are elective cases with lengths of stay greater than 7 days, you can see it's this blue line here, the length of stay with less than 7 days elective cases that are driving this non-random variability in the census. And probably since 1811, when MGH was opened, our operating room was scheduled without, and this is true of every other hospital in the country, without any thought to the downstream impact on the census. Surgeons would decide what day of the week they wanted to work. The OR schedule was densely packed, and really little attention was paid in assembling the OR schedule as to what the downstream impact would be. And then this just blows this graph up a little bit further, and you can see the actual numbers and the magnitude of this non-random variability caused by these elective short-stay patients. So this is how the OR is scheduled, Monday through Friday, 29 rooms. We actually have more than 29 rooms, and each surgeon is allocated a room. This schedule repeats itself every month, and as I said, this is assembled with the intent of densely packing the OR schedule, getting as many patients through it, not with any thought about what was happening downstream as a result of this. And so using some of those techniques that I mentioned earlier, simulation, et cetera, Retzef and the team developed a model to look at what if we simply rearrange the blocks in the surgical schedule, again, now mindful of what the downstream impact would be, could we smooth the inpatient demand for beds and make the hospital operations work a lot better. And so through a lot of effort and convincing of surgical chiefs, surgeons, we actually changed about 50% of the blocks on this schedule. And I love this graph. I didn't put it together, but blocks were moved around. Surgeons changed their OR day in an effort to try to smooth the inpatient census. And the model that was developed showed that if we did this, that we would reduce the midday census by about 10 patients, the midnight census by also by about 10 patients. And as you can see on the weekends, the census would be a little bit higher, but there was plenty of capacity then. A lot of hospitals, when faced with these kinds of bottlenecks, thinks that the immediate answer, there are usually two immediate answers. One is you need to start doing surgery on the weekends, which is very inconvenient for surgeons, the rest of the staff in the OR, and patients. Or the other answer is you need more operating rooms, which is also a very expensive capital and operating investment. So this then led to a series of discussions with the individual surgical staff, surgical chiefs. It became clear that there were some changes that the model called for that just weren't possible, and so some additional constraints were added to the overall model. But through a lot of iteration, the model was ultimately implemented. I should mention that the volume in the OR went up 9%. The length of stay in the hospital went down 5%, but with a 9% volume increase, we only saw a census go up by 1%. So without this change, you would have expected this to go up by 9 or 10%. It went up much less than that. One of the phenomena we face at Mass General is what we refer to as the fire hose effect. No matter what operational improvements we make, no matter what capacity we add, we are just overwhelmed with patients. And so during this period of time, over a year, to have surgical volume go up by 9% was indicative of that. Another issue that was faced in the operating room is wait times for surgical patients getting into the OR itself. We have goals at the hospital that for elective or non-urgent patients, we want them in the OR within 24 hours, assuming they're inpatients. If there's an urgent problem, we want them in the OR in 4 hours. And if there's an emergent problem, 45 minutes. And you can see from this vertical bar graph that prior to this work, we were achieving those goals only 70% of the time. 30% of the time, patients weren't getting there in a timely manner. And so separate from that block reorganization, we also looked at how we were handling elective and non-elective emergent cases. Prior to implementation of this other part of the model, there were some rooms that were, there were a couple of rooms in the OR that some of the surgical services use strictly for emergency cases, but in much of the OR, emergency and elective cases were jumbled together. The OR schedule would be fully scheduled with elective patients, then emergency patients would show up, and people would scramble to try to accommodate them, obviously a less than ideal situation. And so what happened was that the control of the open rooms, the rooms for emergent cases, were centralized, and we also added a few more of those. And we have seen significant increases in the frequency with which patients are getting into the OR in a timely fashion. I used to hear frequent complaints before this was done from surgeons about how they were having to operate in the middle of the night, in the wee hours of the morning on these waitlist cases because the ORs couldn't accommodate them. And seriously, I haven't heard a single complaint along those lines in several years. Maybe it's because I've been traveling more, I'm not sure. So turning from the OR to another important part of the hospital, the use of our inpatient beds. We are in the process of doing a pilot on our neurosciences floors to see if we can improve the flow of patients in our neuroscience beds, and then learning from that, extend that learning across the hospital. This is a complicated process flow or diagram of how patients move in and out of our neurosciences floors. They come electively from their physician's offices, they're transferred from other hospitals, they're transferred from the emergency department, or they're admitted electively for surgery. There are 2 neurology teams. There are 3 different neurology floors, including a 22-bed ICU. There are neurosurgical ORs, and then there are 4 neurosurgical teams. And so Retsev and his colleagues have been modeling with real data the flow of patients in and out of these beds. And it's what's become clear qualitatively is that we reserve a lot of beds. Surgeons, knowing that they're going to be doing a case in the day, the admitting office will hold a bed later in the day for that patient to go to, and so we're doing static bed assignments rather than real time. 87% of our discharges on these floors, and this is true throughout the hospital and throughout most hospitals in this country, happen after midnight. We're a little bit like a hotel where the check-in time is 10 a.m. and the checkout time is 3 p.m. Doesn't quite work that well. We don't have very transparent guidelines on how beds are prioritized. Sometimes beds are assigned without access to all the necessary information. There's sometimes not great communication about which patients are going to be discharged. And about 14% of our neuro-ICU is consumed by patients who are ready to be discharged but have no place to go. So on this static bed allocation, this is the model that we are in the process of implementing. Rather than reserving beds prospectively, we're going to assign them at the time that the patient is ready to move to the bed and when the bed is ready, because there are a significant number of beds that are empty that are caught up through this reservation system. We're also going to work to try to better align those check-in and check-out times and try to get even a handful of our patients out before noontime. And then we also need to streamline the handoff process that is necessary for patients to move from one step to the next. So these are the interventions that are being implemented: just-in-time transfers, early ICU to floor transfers, and early discharges to home as well. And we think, if Retsev model is correct, and it was correct in the case of the OR, that again, we have goals for how quickly we'd like to get patients from one place to another, from the ED to the ICU, et cetera. Right now, we're achieving that anywhere from 43 to 91% of the time. And without adding any beds, simply changing the method we use to assign beds, et cetera, we think we can improve the performance of movement of patients in the hospital quite significantly. And the biggest single impact is this just-in-time policy, getting away from reserving beds and just using them when the patient's ready and when the bed is available. We're applying similar techniques to the other ICUs in the hospital. Again, we have a significant number of patients, 15% of our ICU patients, who are in the ICU for a prolonged period of time and don't need to be there, but have no floor bed to go to. So we're going to be looking at our decision rules for those decisions. And as I said earlier, our internal medicine associates practice is our largest primary care practice. We've applied the expertise of the Sloan School not only in the inpatient and OR setting, but in the primary care setting as well. Before this intervention, this primary care practice has multiple providers. Each one had their own system for handling medication requests from their patients, new prescriptions, prescription refills. It really was a process nightmare. And through the work of Retsev and his colleagues, that now has been centralized into a single drug management office within this practice with much clearer sets of processes and responsibilities, and has dramatically improved the ability of patients to get the prescriptions they need and made the physicians and other staff's lives a whole lot easier as well. And we're also looking at balancing schedules within our primary care practice. The internal medicine associates, a practice I used to work in, has a lot of teaching physicians who were involved in research. The schedule in the practice was often driven by like the OR, the whims of the physicians and what days were best for them to work, without any thought to the chaos that this variability caused within the practice. And what's happening now is that the schedule is being smoothed, and physicians' time in the practice is being modified to make things work better. So just a few lessons learned about our experience with Retsev and the Sloan School, which has been highly positive and which we're extremely excited about. number one, we've tried to prioritize or focus this work on issues of importance to the hospital and to our patients, where we think we have opportunities to make significant improvements in quality, safety, and efficiency. I think it's really important to have data. Somebody once told me early in my career, don't get mad, get data. But being able to drive this process in a very data-driven way has been, I think, very persuasive for the physicians and other staff who initially are pretty skeptical about sort of the wizardry of operations research, but I think we're convinced that it made sense in the end. Culture is important, and and moving the culture along and getting people to accept change is obviously important. Great models don't automatically make people change the work that they did yesterday, tomorrow. So having a culture that supports that kind of change is important. And this has definitely been taken a lot of leadership effort by myself and other members of the management team, including our chiefs, who've been very supportive of this effort and have helped drive it through the organization. And obviously, it's very important to continue to analyze the impact of this, monitor the results. And like I said, this has had not only very positive results on the operations of the hospital, but it has led to very significant academic accomplishments for Retzef, his team, as well as our staff as well. So again, I want to thank Retzef for the privilege of collaborating with him and with his colleagues at MIT, and thank you again for inviting me to join you today. And at this point, I'd be happy to answer any questions that you might have. Thank you.
Hi. I'd just like to know, what were the biggest barriers you had to implementation of this at the hospital?
I would say biggest barrier was to convince the surgeons that this was going to work, because with some physicians, surgeons in particular, if it worked yesterday, then it'll work tomorrow. And so this took a bit of a leap of faith by the surgeons to change their schedule, change their OR days. That meant changing the days that they were seeing patients in the office, changing when they were teaching, doing research. And so it was pretty disruptive to the surgical staff. And so convincing them that this, in the end, would be better for patients, be better for them, because they would be waiting around less to do their surgery, was the most challenging part. But again, because of the clarity of the analysis, and because the leadership was fully behind this, we eventually got that done. And 50% of the surgical schedule was changed, and it continues to be tweaked on an ongoing basis to try to optimize it. Yes?
I had a quick question about quality outcomes. From an operational perspective, this makes a lot of sense. But in terms of results for the patients, is there any data? Does it show any data on the quality outcomes?
I might ask my driver if we have any quality outcomes. I'm certainly not aware that any quality outcomes in our surgical areas have gotten worse.
I don't think that I think that it's very tricky to measure this. I think that it's very common if patients wait less and get time. It's considered like a measure of quality. So in that respect, we definitely improved significantly. You know, for example, you saw the non-elective patients. If you don't see some of these patients in a timely manner, you should expect to see some deterioration in their condition potentially. And so that's definitely clear quality measures that we accomplished. I think that in general, all of the projects are driven by patient-centric goals. We don't do things, we don't try to cut costs in our project. We try to improve the patient experience. That's kind of the goal of all the projects. I think the cost cutting is come and the efficiencies are come as a byproduct usually. I don't think that there was any worsening of it.
Yeah, actually, surgical readmission rates have come down. Whether that's due to this or other things, I'm not sure. Yes, sir.
Is this on? Yeah, it's working. I'm from Washington, and I'm not here to help, but
Washington,
D.C.
D.C., D.C., yes.
So listening to all the presentations, and I've sold in a couple businesses to the hospitals many times, and watching the quality improvement discussions and the economic discussions, I wanted you to comment, if you would, on how much the Medicare readmission policy and coming initiatives like that are driving change within the hospital, and how much that offers you an opportunity to change culture and processes, because your revenue is being now influenced by your payer as to how you operate your business.
Right. I mean, I think these incentives or penalties help focus the mind some, and probably on balance are a good thing. I guess the biggest problem I have, I think there was a lot of excitement about readmission reduction a few years ago. I think a lot of the excitement is, well, the excitement is a lot less. It's a lot harder to reduce readmissions. I mean, people are, a lot of patients who are readmitted are very sick and fragile, and their human biology results in them needing to be back in the hospital despite best medical efforts. I guess the other problem with the readmission policy as it now is in place is that the readmission rates are the highest among low-income populations. And so right now, hospitals that serve those populations are being penalized. The federal government is not adjusting the data, the readmission rate data for differences in hospital demographics. So in some ways, the hospitals that need more resources to care for disadvantaged populations are being penalized because they do so, and I think that's not, that needs to be changed in some way. Yes. I can't see who has a microphone. All right, great, sir.
I just wanted to see if we can combine two of the talks and get you to comment on it. So Professor Doyle's talk addressed the efficient allocation of resources to patients outside the hospital to address chronic care conditions in the community. And Professor Levy's and your perspective addressed the efficient allocation of resources inside the hospital. What do you see as the opportunities to integrate those approaches to address the patient's needs both inside and outside? And I'm saying this recognizing that Partners is one of the leaders in telemedicine approaches and other innovation.
Sure. I mean, I think there are obviously, I mean, I truly believe that the biggest healthcare problem facing our society is the rising cost of healthcare, and unless we are able to bend the cost curve and figure out ways to make care more affordable, high quality care is not going to be affordable for many people in this country. And so we need to innovate as quickly as we can to try to prevent that from happening. And I think we need to throw the kitchen sink at it. So we need to do all of the things that you were just describing, because they are attacking different parts of the cost challenge. If we can make hospital operations more efficient, then hospitals presumably can survive on lower unit payments. If we can better coordinate care in the community, people will need hospitals less and will be able to drive down utilization rates. If we can use drug therapy more rationally, then we can reduce the expense for pharmaceuticals. So we are working probably on dozens of different strategies to try to drive healthcare costs down. You mentioned telemedicine. We are very bullish about that. We now have, in a couple of different specialties, programs in place where primary care physicians seeing a patient, for example, who needs a cardiology question answered, formerly would have needed to schedule an appointment with that cardiologist. Now we're actually paying a cardiologist to be available via telemedicine to answer that question with the primary care physician and the patient there in the room. So we're doing these specialty virtual visits to try to make care better for our patients, but also to reduce the trend in healthcare expenses. So there are probably a dozen different strategies. They have to be prioritized, but ultimately they all need to be pursued in order to try to prevent our healthcare system in this country crashing into the rocks of unaffordability. Yes, in the back.
Yeah, hi. I appreciate all the efforts you're doing to mitigate risks of patients as they become risk-bearing entities to your institution and others, through value-based initiatives like bundled payments and others. I'm wondering if you've done anything specifically to manage medication adherence at Mass General, and if that's something that you've seen any promising initiatives on or interventions.
I'm not, I mean, certainly we've done a lot of work trying to move patients from brand name drugs to generic drugs. We've done a lot of work on our formulary in an effort to, I mean, make sure we have drugs that we need, but also have a few drugs in a class so that we have some pricing leverage with the pharmaceutical industry. I'm not sure that we've gotten yet to the issue of adherence. I know we've certainly been approached by all sorts of vendors who are interested in helping us with that, but I'm not sure. I'm not sure we've gotten to that. I think there are some other higher priority things that we've been focused on, but we will eventually get to it. I should mention, answering these two questions, if there was one thing that you wanted to do to try to manage the cost of a population, I think it would be to better coordinate the care of the 10% of the population who are responsible for 60 or 70% of the cost. I think that is the single biggest arrow we have in our quiver, but there are lots of other arrows with lesser potency that we also need to take advantage of as well. And I think in the case of drug adherence, it's just far enough down on the list that we haven't quite gotten to it yet.
Hi, you've mentioned bending the cost curve a few times. How rapidly do you believe the cost curve needs to be bent? Timescale.
How rapidly?
How rapidly? Is it 5 years? Is it 10 years? How much do you think you need to bend it by?
Well, I think there's already evidence that it is being bent. If you look over the last few years, Medicare expenditures per beneficiary have come down. The federal government uses, the Congressional Budget Office uses 10-year models of Medicare expenditures to predict the future, and that shows continued worries about a federal deficit going forward. If you use Medicare trends over the last few years, the future federal budget deficit goes away. Whether what we've seen in the last few years is due to the economy or due to some fundamental changes in the healthcare system, only time will tell. But I think there's some evidence that we are bending the cost curve. In Massachusetts, the state has set a goal of keeping costs growing no faster than the growth in the state economy, and so far we've been successful at doing that. Yes, right here.
What is the next step for the collaboration between MIT Sloan and Mass General? Is there a commercially available optimization module? Is that something that's in the works?
I'm not aware of any efforts to commercialize this. We published it, want to make it available, the approach available to others. Retzef, do you want to comment on that?
Hello? Yeah. I think that so far our approach was that we want to disseminate the knowledge in the community without making money out of it. But maybe we'll change our mind.
Yes, over here. Yes, sir.
How do you define and audit adherence to best practices?
In lots of different ways. One program that we've had in place for a number of years at Mass General, we developed our own radiology order entry system where physicians, they want to order an outpatient CT, MRI, PET scan, need to use a system that we've developed that provides real-time decision support that gives them either a green, yellow, or red light as to whether that test is appropriate for the patient's conditions. Physicians can override yellow, red lights, but we audit the results. And in some cases, we found that that the guidelines needed to change. The underlying thinking behind the guidelines were wrong and the physicians were right. But in other cases, I think physicians have learned that their practice patterns need to change. So that's just one of a number of examples where we try to audit results and use the results of those audits to improve performance. Yes?
What is your view of medical tourism, and do you think it has any impact on your hospital today, and do you think it will in the future? And is that a good thing or a bad thing?
Yeah, I'm not particularly worried about it. I mean, when you operate in parts of the world where wages are 1/10 what they are here in the US, I don't think it takes rocket science to be able to make that care less expensive than it is here. I think for places like Mass General, there is a growing number of extremely wealthy people in this world. still think that the best care in the world is available in the United States, and so we are actively trying to attract those people to our institution. So I think there are more opportunities globally than there are risks associated with tourism. And if you look at domestically, there have been a lot of efforts over the years for major companies to enter into contracts with insurance companies to try to direct patients to centers of excellence here in the U.S., where they can get care at a lower out-of-pocket cost at one of these centers of excellence. The uptakes on these products have been minimal. People would much prefer to have care near their home so they can be with their loved ones. So I think that's a deterrent for these products catching on in a major way. Yes, way in the back.
Hi, I'd like to ask you to comment on what you think the benefits to the nation are for imposing, I guess we can say, ICD-10 and some of the meaningful use standards that are, obviously coming to bear on all of the different hospital and healthcare systems.
I guess in reverse order, I think meaningful use on balance is a good thing. It was developed by a physician who used to be at Mass General, David Blumenthal, when he was the director of the Office of the National Coordinator. And I think it has, with the incentive, sort of moved the IT capabilities of healthcare across this country ahead. Sometimes we quibble about whether they need to be as detailed or as prescriptive, but I think on balance it's been a good thing. I wish I could say the same about ICD-10. The amount of money that is now being spent to modify information systems to accommodate ICD-10 is extraordinary. The amount of training that is going to have to go into largely our physicians about how to code for their services going forward is extraordinary. And I'm not aware of any evidence that it makes care better or more affordable. So we're transitioning from an ICD-9 coding system for medical care to ICD-10, which has, I think, 5 or 10 times more codes associated with it. So rather than billing for sewing up a laceration as a code for a laceration, now there are separate codes for a laceration due to a shark bite and a laceration due to a recurrent shark bite. So I'm just not sure that we need that much precision in our coding to be able to make care better and more affordable. It is more precise. There's a heavy cost associated with it, and I'm not aware of any evidence that cost, and with the higher precision that it brings, is meaningful.
I'm gonna ask you some more about ICD-10 because, joking aside, ICD-9 was developed in 1979. Mortality coding using ICD-10 was adopted in the US 10 years ago. So you basically have a situation right now where you can die of Ebola and it'll show up on your death certificate as an ICD-10 code, but you cannot be diagnosed with Ebola under ICD-9 because it didn't exist.
So there needs to be some updating of ICD-9, but I'm not sure it has to go to the extreme that ICD-10 goes to. I agree with you. I see a hand right up front here.
Somewhat tangential to your talk, have you accumulated any data about the operational efficiency of the hospitals that you've acquired? Because you've been growing by acquisition quite a bit. Is it improving those hospitals? Can you prove that it's improving those hospitals with data?
So the question is, can we show that we're improving the efficiency, the quality of the care at the hospitals? I'm not aware of any, I couldn't point to any data per se, but if you were to talk to the people at those hospitals, the physicians, the boards, leadership, they think they benefited enormously and that it was one of the best decisions they've made. So be it Martha's Vineyard Hospital, Nantucket Cottage Hospital, Newton Wellesley Hospital, I think the organizations that have joined our health system feel that by leveraging sort of the clinical managerial expertise at the MGH and the Brigham, that we've been able to help them, and also by, I guess, picking up on what Retzef was saying, trying to figure out ways to move care from the academic medical centers to a community setting with our physicians sometimes being involved, I think they've seen as a big boon to the quality of the services that they can provide. I think Retzef needs his microphone on up here up front.
So I just want to thank again Dr. Slavin for a great talk, and I think we are about to take a break until 15 minutes until 4:15. So see you soon again for the rest of the day. Thank you.
Thank you.